Hey everybody, welcome back to my channel. Today we're going to be talking about SBP, which is spontaneous bacterial peritonitis. So let's start with the pathogenesis of SBP. Give me a sec, please, excuse me. So the pathogenesis. Let's say that we have a patient with cirrhosis and they develop portal hypertension. This again caused them to have ascites. Now when this ascitic fluid gets infected, right, that is what causes a person to develop spontaneous bacterial peritonitis. And the way that happens is, so it's important to know one thing about cirrhosis, and that is that cirrhosis causes altered bowel movements and altered bowel immunity. And these two together, what they result in is that there is going to be bacterial translocation from the gut into the lymphatics and then into the ascitic fluid. There's going to be a translocation of the bacteria. Now that will present as SBP, right? Now how do you how does the patient with SBP present, right? Let's talk about the presentation. So what you're going to see is a patient who has had liver dysfunction for quite a while, comes in with fever, chills, altered mental status, signs of hepatic encephalopathy. This is both because of the infection itself and because of some degree of hepatic decompensation. They're going to have a distended stomach, right? Like distended belly, more like distended abdomen, and they're going to have abdominal rigidity. They're going to have rebound tenderness, abdominal pain. So this is how SBP presents. Now, how do you go about diagnosing a case of SBP? So the first thing that you have to do, I know that people are going to jump and say, let's start them on antibiotics. That's not the first thing to do. The first thing that you have to do before you start antibiotics is to do diagnostic paracentesis, right? So in this, what we're going to see is that first of all, the polymorphonuclear cells are going to be more than 250 cells per mm3. The protein, right, is going to be less than 1 gram per deciliter. An index called SAAG is going to be more than 1.1 grams per deciliter. I'm going to tell you more about SAAG in a minute. And then the last thing we want to talk about is that there can be an elevation of LDH. Okay. Now, before we go into SAAG itself, I'm going to first tackle how we manage this condition, and then we can go into SAAG a little bit. So how do you manage, right? Manage this case of hepatic encephalopathy. So the first thing you want to do is you want to give them 2 grams of cefotaxime, a tally, for at least 5 days, so 5 to 7 days, right? And you want to give them IV albumin. I believe it was 1.5 grams per kg. Let me just, yeah, 1.5 grams per kg of IV albumin. I will touch upon this also as well, because I want to talk a little bit about hepatorenal syndrome. This is mainly to prevent that from developing. So that's going to be cefotaxime and IV albumin. In this, you're also going to get a positive culture, and usually the organisms that you're going to detect are going to be gram-negative enterics like E. coli and Klebsiella. So that's one more thing that I forgot to mention. Now, there are two topics that I want to touch upon, which are very relevant to this what we're talking about right now. The first one that I would like to talk about is SAAG, right? So SAAG is serum ascitic albumin gradient. Now, what this really stands for is that if the gradient, right, if this gradient is more than 1.1, then we are going to have, then it means that there is a presence of portal hypertension, right? And if it is less than 1.1, then there is no portal hypertension. The main reason we do this is to find out whether the patient has portal hypertension or not. Now, if I were to tell you that SAG is more than 1.1, your differentials for this case will be, first of all, cirrhosis with ascites, right? And then cardiac cirrhosis and Budd-Chiari syndrome, right? And if it is less than 1.1, your differentials will be a little different. So you can think of this as pancreatic ascites, or ascites secondary to nephrotic syndrome, right? Now, let's talk a little bit about why we want to give IV albumin. Okay, we are going to talk a little bit about a very challenging complication of SBP, which is what we call hepatorenal syndrome, right? Now, the pathogenesis of this is that, let's say that there is ascites and portal hypertension and splanchnic vasodilation, like splanchnic vasodilation. All this is going to cause your blood volume to be low, right? Because you have like ascitic fluid here, you have like a splanchnic vasodilation, which is sort of contributing to the ascites. All of this leads to reduced renal perfusion. Okay, now let's go back to the basics. What have we heard of when we think about reduced renal perfusion? The first thing that needs to come to your mind is the activation of renin-angiotensin system. Now, when this gets activated, you know that there's aldosterone, there is angiotensin 2, and this causes renal vasoconstriction, right? Renal vasoconstriction, because it is trying to protect the renal perfusion, right? When this happens, all of these together lead to oliguric acute kidney injury, AKI, right? So you want to give the patient with SBP, you want to give them IV albumin in order to prevent the development of hepatorenal syndrome. But like before all this happens, if you preemptively give them IV albumin, you're already improving the renal perfusion, because all this started because there was less renal perfusion. So if you gave them IV albumin, your sort of preventing that pathogenetic mechanism from being activated. So you give them IV albumin and you increase renal perfusion and you prevent the patient from going into hepatorenal syndrome. But if at all the patient were to go into hepatorenal syndrome, what you would then have to give is splanchnic vasoconstrictors, namely octreotide plus midodrine. That is the one that is most studied, but also alternatively you can give them norepinephrine. So I hope this video was helpful. I tried to tie hepatorenal syndrome and SBP together because that is one of the important complications of SBP that you may be tested on. I hope that this was helpful. I sort of tied the whole thing together. I don't know if this is visible, but please feel free to take a screenshot, or I can just enlarge each of these sections for you to take screenshots if you need to. If you want to take screenshots and add them to your flashcards, or sort of use this as sort of a skeleton for you to like learn these concepts and reason them out for yourself. So this is about it for SBP and hepatorenal syndrome. I hope you guys enjoyed my video. I apologize for not being more active on my YouTube channel lately. I've been stumped with so much work, but I've been trying my best to be a good medical education YouTuber to you guys. Study well, take care, and good luck. I will see you guys soon. Bye.